Hi, I'm Tracy Johnson. I'm proud to be the CEO of Inala Primary Care, which is in Brisbane's western suburbs. We're a large general practice. I'm privileged to lead a team of doctors, nurses, allied health, and indeed some health and social care researchers. We deliver what you typically see in a general practice plus a whole lot more. I have an unusual but perfect CV for the role that I currently occupy. So my technical qualification that makes me perfect for healthcare is actually economics. But having started out in merchant banking, I now find myself as the CEO of a charitable general practice. So what's been my journey to get there? I find healthcare and the science behind it fascinating. I find the team dynamics and the interactions between different players something that needs to be leveraged for benefit for patients. And I'm passionate about communities. So by working in healthcare settings, as I've done since I was in my early 30s, I've found that I can leverage the skills of great teams with great commitment to get better outcomes for the community and for the patients we serve. At Inala Primary Care, we're privileged to serve 7,000 patients in Queensland's largest social housing suburb. What that means for us is that we see patients where the social determinants of health are real. We have above average rates of every form of chronic condition you can mention. We have the state's highest rates of mental health presentations, highest number of patients on disability support pensions. We have the full calamity, but our privilege is actually to work in Queensland's most multicultural community. So with that, we end up with patients who've got complex chronic disease, an overlay of mental health, poverty, housing instability, lack of cars, and often lack of language, because 25% of our care is delivered with interpreter support, meaning that we really get to see and serve patients that are hard to serve, hard to advocate for, and often largely ignored. So if we can make healthcare work there, we can make it work anywhere, and that's what my team has tried to do. In our wonderful suburb of Inala, what we've really looked at is where do patients go on their journey? Do they need to stay in community settings? Do they need to go to hospital environments? And what we've found increasingly is that there's lots of general practitioners, allied health providers and nurses that are prepared to step up and work to their full scope of practice. So what we've done is we've looked at the needs of our community, because we take population health and our service of that community seriously. And we've decided that there are areas where there's gaps. So our first experiment was to approach the hospital system about patients with complex diabetes, and we now run an outpatient replacement model. We've been doing that for a decade. It's been studied by the Productivity Commission and a bunch of independent research groups, and what it's shown is that we can deliver that care 50% cheaper with 75% fewer hospital admissions, and patients love coming to a local GP practice rather than hospital environment. The recommendation of the Productivity Commission was that that model of care be rolled out nationally, saving the system well over $300 million a year. Spurred by that success, we decided to look at renal care. We've also looked at hepatitis, both of which we have well above national burden in our local community. And our philosophy has always been, how can we resource share? How can we leverage each other's strengths? Which is why we've got all of these great partnerships between hospital and other providers and ourselves, so that we mix and mingle and do the right thing by our community. Not always easy, involves novel corporate governance, involves some savvy negotiating, involves getting people to work together that are not normally used to working together, and focusing on common targets that we can agree on in a system where sometimes the incentives for performance don't line up with patient need. Still, we keep doing that. So more recent things that we've done, we actually have embedded pharmacists in our general practice. They provide a really interesting role where they're relieving our GPs of work that GPs have found themselves doing for too long, and have in fact freed up our GPs not only to provide care to other patients, but better care to the patients that the pharmacists are involved with. So our pharmacists liaise with local community pharmacy to make sure that medication reconciliation occurs. They look at all of our discharge summaries to make sure the hospital's provided us with sufficient information to continue care for that patient. They participate in case conferences around our more complex patients. They deliver shared medical appointments alongside our doctors and health assessments. How do we fund that? Well, there's a home medication review item number which partially covers their salary. The rest of it is something that as a practice we've decided is important because we're actually saving hospital admissions through that model. We've also got models around social prescribing and care coordination, again using partnership funding from Brisbane South Primary Health Network, which is where we're based, and other partners like MARTA, where they've given us philanthropic money to bring in social workers and nurse care coordinators. So again, the question that we're constantly asking is, where should we be providing this care and who with? In the process, what we're finding is we can do more and more in general practice if we get the team right, the funding right, and the focus on the patient right. Successful transitions in care in Australia. It's a really interesting phrase, isn't it? If you look at the data from the Commonwealth Fund, transitions in care in Australia are in fact amongst the worst in all of the countries that the Commonwealth Fund studies. So less than a quarter of the patients who are admitted to hospital get timely information back to their general practitioner, so we know whether that patient's even been in hospital, let alone what we're expected to do once the patient's out of hospital. It's an even worse indicator if we look at what happens with residential aged care facilities and hospitals. So we've got all of these patients navigating their way through the healthcare system, data doesn't follow them, shared care isn't available to them, so as a consequence they represent to hospital. So what can we do around transitions in care? Well, for a start, it'd be nice to get discharge summaries that actually include a full medication list as soon as possible after the patient's left hospital. We find some departments never provide those, and so we have to make up the difference, which means we really need to start thinking about our investment in digital health, our investment in care coordination type models, and also enabling patients to advocate for themselves, because a lot of our patients assume that information follows them and that we know what's gone on with other care providers, whether they be allied health, hospitals, or other services. So certainly strengthening the funding that's available to make our teams truly a team across the different spectrum of healthcare provision, as well as making sure that data is available and that it's clean and that it's relevant. My Health Record is one part of that, but it needs incredible augmentation, which is why looking at shared care planning, case conferencing, and a range of other face-to-face as well as virtual enablers will enable us to stop patients bouncing back into hospital because what people were expecting to happen to them hasn't happened. The elderly are a growing proportion of patient care in every healthcare setting. We need to be real about that and acknowledge it. So in general practice, in 2016, things tipped. More than half of care delivered in general practice from 2016 onwards has been with these complex, frail and increasingly older people. What does that mean in terms of where they end up and our pre-admission and post-admission discharge planning? It means that we need to get our ducks lined up in a row. It means that we need to have teams who are actually filled with knowledge about what geriatric and frailty care looks like. General practitioners in the past haven't really had to concentrate on that to a great degree. Guidelines don't exist, templates are inadequate, tools are impossible to follow. So what we really need is a concerted effort as a community to say people want to age well and at home. That means our primary care setting needs to be enriched with all of the supports that we need to keep these patients well, choosing the lifestyles that they want, and managing themselves well in community. So what we're attempting to do is create a centre of excellence around ageing and healthy ageing in community settings in particular. We've got nodes identified throughout the country. We've got commitments from different health funders that are interested in joining, because they too see that if we can keep people going to see their general practitioner, going to see their local pharmacist, going and being supported by their allied health providers, it's better for the patient, they feel less medicalised. It's better for the system because it's far lower cost. And ultimately we can keep people functioning at higher levels of performance rather than deteriorating. But to do that, we need to have some honest conversations with the patients and their family about the fact that ageing is inevitable. I've got ageing, everyone's ageing. We're all going to die at some point, and these are words that are hard to hear. So it means we need to be more approachable in our discussions about what it means to get older, what it means to be dying, because we're all dying. So to do that, we need to be talking about advanced care planning years before those advanced care plans are necessary. It means that we need to talk about patient choices way before those choices need to be made, and including their family and carers in that. It means that we need to be talking to all of those people around the patient about what their preferences and needs are for support and what their capacity is to activate themselves and live the lifestyle that's needed to manage their medications, to manage their multiple diseases. Because as we all get older, we're all going to be on more and more medications, have more and more diagnoses, but not necessarily want to be defined by our age or our disease. So we need to think clearly and carefully about what the decades ahead are, rather than letting the system fail and then choosing to respond when it's too late, which is what happens now. Preventable hospitalisations in this country cost us literally billions of dollars a year. Hard to track the exact number because there's so many reasons that people end up in hospital and inappropriate settings, but I'm a big believer in right care, right time, right place. So what does that mean? It means that we need to be thinking about the patients and what their needs are before they become so acutely unwell and unstable that we need to send them off in an ambulance to hospital. Unfortunately, at the moment, the funding model for general practice is a reactive model, not a planned care model. If we knew who our patients were, they knew that we knew that they were our patients, and that together we could work on what their needs were as a patient population, we would be anticipating when people are becoming unstable and decompensated, intervening earlier, using a team of care around them. So that team would include nurses, allied health, pharmacists, and indeed other specialists. And we'd be working together to change the trajectory for that patient so that we had fewer hospital presentations. What happens now is we tend to rely on the patient to identify when they're sick. Patients are often not good at doing that, so they turn up too late, by which time there's little that we can do to intervene other than get them in hospital. So if that's our current circumstance, let's start working on early discharge processes so that patients can be returned back to community where they're going to be happier, where the care is cheaper. But what it means is that we need funding for the allied health and nursing in community settings that's going to allow them to restabilise, hopefully rehabilitate, and achieve the sort of life that they were on task to achieve before they got unwell. In general practice, that means that we're going to need a lot more funding to build those teams around the patients, because at the moment team-based care is really a general practitioner with a nurse as a handmaid has really been the model of funding that we've got through the MBS. So I'm looking forward to bundled payments arriving, voluntary patient registration being real, funds available to allow us to draw down more allied health supports and more pharmacy supports, and indeed be able to case conference much more regularly with our hospital colleagues and build those hospital colleagues in some of our models of care, rather than saying because you're a specialist physician you automatically have to work in a hospital. Let's bring care to where patients need care. Let's bring care out of hospitals into community settings so that we get right care, right place, right time, right team, which often means the right system. And at the moment, the systems to enable all of this don't exist. We don't have interoperability between what my patient record is in primary care, what the hospital system record includes, what the IDs are so that we can even match patients, nor do we have some of the face-to-face enablers where I can ring and get a quick advice from a physician in a hospital to avoid a referral or to avoid a presentation, nor do they have much success ringing us in general practice and saying, hey, we're wanting to discharge this patient, can we talk to you about how to do that well? So we need both funded time for the people stuff, funding for the system stuff, and funding for much larger teams so that everyone can work with the best interests of the patient in mind.